Namaste. हमेशा खुश रहो. Today I am discussing a session that is important when we are taking radiographic images of different regions. So it is a session is particularly important when imaging of the course name is radiographic techniques of full body in BScRT second semester. Okay. I JV'N Gaurav from the Faculty of Physiotherapy and Diagnostics and in the Department of Diagnostic Community Health, JV'N University, Jaipur. In today's session, we will discuss about the lumbar spine flexion or extension view of it. The lumbar spine flexion and extension view images the lumbar spine which consists of fiber tissue. Indications these views are specified or specialized projection to provide functional test. Lumbar spine instability often is in the context of spondylolisthesis. Spondylolisthesis. Okay. Patient position. The patient is positioned erect. Ideally, spinal imaging should be taken erect in the setting of non-trauma conditions. To give a functional overview of the lumbar spine. All imaging of the patient with suspected spinal injury must occur in the supine position without moving the patient. In the lateral decubitus position of the patient, so that the humerus are extending 90 degrees to the thorax with the elbow flexed so the forearm are parallel to the thorax. Spinal curvature in the AP projection will determine if a right lateral or left lateral is performed. When implementing horizontal beam technique, ensure the distal upper limb are not overlying the region of interest. So, what is flexion or extension? At the last possible moment, instruct the patient to bend forward from the lower back, flexing their lower spine. Okay, flexion. Bend forward. Okay, from the neutral. Extension. The instructs the patient lean back from the lower back, essentially extending their lower spine. The technical factor or exposure factor lateral projection होता है. It is a lateral projection expiration to minimize superimposition of the diaphragm over the upper lumbar spine. Centering point. The central ray should pass through the level of the E-rectus. Coronal centering point is directly over the lumbar vertebrae, which correspond to the posterior third of the abdomen. The central ray is perpendicular to the image receptor. Okay. Next one is the collimation. Superiorly to include the T12 or L1 vertebrae. Inferior to include the sacrum. Anterior to include the anterior border of the skin or lumbar vertebral body. Posterior to include all elements of the posterior column, particularly in the spinous process. Orientation. The orientation should be used, or the cassette orientation should be used. Portrait detector size or cassette size 14 by 17 inches or 35 by 43 centimeters. Exposure factor is in the range of KC 70 to 80, MAS 40 to 60. SID 0 or 100 centimeters. Grid, yes, grid is used. Ensure the correct grid is selected if using focusing grid. Image technical evaluation. The anatomical affliction to demonstrate flexion and extension to entire lumbar spine should be visible from T12 L1 to L5 S1, T12 to S1. Okay. Adequate image penetration and image contrast is evident by clear visualization of lumbar vertebral body with both clavicular and cortical bone demonstrated. Okay. So the next is practical point. Physical demonstration of the projection is often best to ensure patient fully understand the procedure, ensure centering is adjusted when the patient moves into the position, and utilize an erect bucket when performing horizontal beam laterals to utilize oscillating grid, automatic exposure control AEC, and CR/IR alignment. If the patient demonstrates spinal scoliosis, ensure that the side with the convexity is closest to the IR image receptor. This will utilize the diverging beam and aid in achieving superimposition of the upper and lower end plate. Try to remove as many possible image artifacts, especially when performing horizontal beam technique in the trauma condition. So, I think you have understood well after after uh, after studying or listening the session or lecture. After listening the YouTube video or this YouTube video, or this, I think this will very helpful for you to position the patient or what we can get from the patient image. So it will be very helpful for you. Or thank you. Namaste. In today's session, we will discuss about the lumbar, AP, and lateral view. Lumbar spine, anterior posterior image is the lumbar spine in the anatomical position. The lumbar spine generally consists of 5 vertebrae. Lumbosacral transition vertebrae indications for taking the lumbar spine AP view images. Indications. This projection is utilized in many imaging contexts, including trauma, post-operatively, and for chronic conditions. Chronic condition, spinal imaging should be taken erect in non-trauma conditions to give a functional overview of the lumbar spine. Otherwise, patient with a suspected spinal injury must remain in the supine position without any movement. Patient position. The patient is erect or supine depending on clinical history. In the supine projection, hands are placed by the patient side. Okay. If performing erect position the patient in the PA. This has numerous advantages, including reduced dose to the gonadal region and utilization of beam diversity. Arms can be placed by the side or the handlebar of the erect bucket can be held for the patient's stability. The weight-bearing PA view can be called the Ferguson technique. Okay, this is the AP erect or PA. Technical factor, exposure factor. In this view, suspended exposition of patient is required. Center point, the level of the iliacus at the mid sagittal plane. The central ray is perpendicular to the image. Means it is image receptor. The central ray is perpendicular to the image receptor. Collimation superiorly to include the T12 L1 junction, inferiorly to include the sacrum region, lateral to include the transverse processes and sacroiliac joint, SI joint. Orientation should be portrait, and the detector size that is used is 14 by 17 inches or 35 by 43 centimeter. Exposure factors for the lumbar AP view is 65 to 75 kVp, or MAS is in the range of range of 30 to 50 mm. SID 100 centimeter grid. Yes, grid is used because high exposure radiation is delivered in this view. Image technical evaluation, the entire lumbar spine should be visible with demonstration of a T11, T12 superiorly and a sacrum inferiorly. No patient rotation as evident by the central spinal processes and the symmetrical appearance of the sacroiliac joint or iliac wings. Intervertebral joint are visualized. Adequate image penetration and image contrast is evident by clear visualization of lumbar vertebral bodies, pedicles and facet joints and both clavicular and cortical bone demonstration. So we can visualize the parts of the vertebral column or vertebral body, pedicles, facet or trabecular or cortical bone. Okay. So the practical is the three columns. The concept of a thoracic lumbar spinal fracture is of particular importance when assessing the image of the pathology. Take particular care when imaging patient on a trauma trolley. Then the image receptor is aligned to the central ray to prevent anatomy exclusion or grid cutoff. Okay, so this is the lumbar spine AP view. Next view is the lumbar spine lateral view, which is the lumbar spine which generally consists of 5 vertebrae. Lumbar 5 vertebrae. Indications. This projection shows an orthogonal view of AP and it is utilized in many imaging contexts, including trauma, post-operative, chronic conditions. This view is also ideal in characterizing spinal alignment. The spinal imaging should be taken erect in the non-trauma setting, non-trauma conditions or non-trauma position to give a functional overview of the lumbar spine. Otherwise, patient with a suspected spinal injury must remain in the supine position without any patient position. The patient is positioned erect, supine or lateral recumbent depending on the clinical history. In the lateral equidistant position, the position of the patient so that the humeri are extended 90 degrees to the thorax with the elbow flexed so that the forearm are parallel to the thorax. Spinal curvature in the AP projection will determine if a right lateral or left lateral is performed. When implementing horizontal beam techniques, ensure the distal upper limb are not overlying the region of interest. The technical or exposure factor expiration to minimize superimposition of the diaphragm over the upper lumbar region or spine. Centering point, the level of the iliac crest. The coronal centering point is directly over the lumbar vertebrae, which corresponds to the posterior third of the abdomen. The central ray is perpendicular to the image receptor. Next is the collimation. Superiorly to include the T12, L1, inferiorly to include the sacrum, anterior to include the anterior border of the lumbar vertebral body, posterior to include all elements of the posterior columns, particularly the spinous process. Orientation should be portrait. It exercise is in the range of 14 to 17 inches. Exposure factor that is used is in the range of 70 to 80 kVp and MAS 40 to 60. SID 100 cm is used. Grid, yes, grid is used because of using high exposure factor. Image technical evaluation or radiographic appearance, the entire lumbar spine should be visible from T12 L1 to L5 S1. Imposition of the greater sciatic notches, the superior articulating facet and the superior and inferior end of plate This indicates that true lateral has been achieved. Okay. So this is the view of lumbar spine lateral. So I think these views or these knowledge, this knowledge is very much useful for you, or you can get a good knowledge or good practical exposure after listening or correlating with practical exposure in hospital. Okay. Thank you. Thank you. The session is over. I think you are satisfied with the session. If you have any query, then put it into the comment box. I will resolve it later. Thank you. This session is powered by digital version 2.0, created with Women's University, Jaipur. The session is over. Thank you.